North East London, a chair of North East London CCG. I'm really happy to introduce my two colleagues, Tamsin Bicknell, our consultant midwife at the Homerton Hospital, as well as Dr. Ellen Schwartz, our consultant in public health medicine and City and Hackney public health COVID-19 lead. We are here as people that are been working on COVID-19 over the last 18 to 19 months and have lots of experience of this as we go forward. As a GP, over the last 18, 19 months, you can imagine many of my colleagues have been doing the vaccination. I have been part of that, vaccinating, as well as also supporting some of our vaccination centres, as well as some of our questions that we have had as we've gone along. It has been a very hard 18, 19 months for our NHS staff and frontline staff, particularly our colleagues in the hospitals, as well as also our frontline GPs, as well as our social care and care professionals in the local authority, all really there to help and support our residents and public with the COVID-19 pandemic. So it's been a hard slog, but in a sense that we have been through a difficult time, but at the same time, we've been part of a unique situation where we've come together to help and support our residents going forward, but also trying to bring the UK and particularly North East London for us back to some kind of normality. So on that note, we are going to talk on different aspects of this, give some questions and obviously answer any questions that we get, and also share our experience and give you some help on terms of where you can get vaccinated and what concerns you may have. We hope we can answer. If we can't, we're very happy to take it offline and come back to you through our team at North East London CCG. So on that note, I'm going to introduce my next colleague, Dr. Ellen Schwartz, who will talk about the vaccination and the COVID levels. Ellen, if you can introduce yourself and talk about your experience.
Yeah, thank you very much for the introduction, Jagan. So I'm Ellen, nice to meet you all. And as I was introduced, I'm a consultant in public health medicine, just recently started at the City and Hackney public health team, and I was kind of moving to other areas in London prior to this, and I've been working on the pandemic pretty much exclusively since it started. And just to reflect on where we are with this pandemic at the moment, as you are all aware, incidence is high, and there are levels of concern and reintroductions of lockdown and other measures across Europe and elsewhere in the world. And levels are also high of infections in the UK, but that is in combination with a very successful vaccination campaign. So we've seen high levels of incidence pretty much from the summer across London and in North East London. Positivity remains high. Levels of people in hospital, Tamzin will talk more about this, are also significant. But we are still in a situation of relative steady state in terms of relative to other countries where the development in terms of seriousness is much more rapid, and that is at least in part due to the successes around the vaccination. Just a couple of words on the vaccination. The vaccination is there to prevent us from developing serious illness or death. That's the aim of those vaccinations. and it does its work really, really well. It doesn't mean that vaccination prevents us from actually getting infected or passing on the vaccine. That's why it's really important that we all continue with other measures to prevent the transmission. So when we're ill, stay at home, get your PCR test, or test regularly, even if you don't have symptoms, and don't go to a Christmas do without any test before it. And then also these other measures like having a face covering in very crowded places, ventilation, hand washing, those kind of measures that we're very familiar with. And we're going to talk about the aspects of vaccinations now, but I just wanted to tell you this as well, because it gets often forgotten that those other measures are very important. Thanks.
Thank you, Ellen. I'm just going to then quickly, before we start opening up to the questions, I'm going to talk to and introduce my colleague, Tamzin. Tamzin, if you can introduce yourself and then some of your reflections, some of your views in your as a consultant midwife at the Homerton, obviously being in the hospital. Thank you.
Thanks, Jagan. So I'm Tamzin. I'm a consultant midwife with a remit in public health and safeguarding. I usually work at Homerton, but the last few months I've actually been working at Barts Hospital, so across Whips Cross, Newham and Royal London hospitals too. So I've had the chance to see what's been going on in other parts of the North East London area. I think what we have seen, and not just in our area, but across the country, is that the Delta variant really affects pregnant women more seriously than previous variants did. And I think that's why it's so much even more important than it was before for women in pregnancy to take up their vaccine, or ideally before you even become pregnant. So if that's something that you're thinking about, then it's good to get that done first. I think we've seen numbers of pregnant women becoming very unwell with the Delta variant and needing hospitalisation and needing ITU care. So that's the most serious level of care that you can have. And actually, I spent a number of hours a few weeks ago with a lady in ITU who was pregnant, and she was very unwell and she was very, very scared, understandably. And she is still there, and her baby had to be delivered early to make sure that her body had the best chance to recover from the COVID that she was experiencing. So I think, this is a very real risk. And I think the message that we want to get across is that the benefits of having a vaccination, it's just a really easy, safe, positive step that you can take to protect yourself and protect your baby. And actually, we've seen that some evidence coming out now that we were right to think that babies would be protected by the vaccine if you have that in pregnancy. And that's the same idea as that we use when we give the whooping cough vaccine in pregnancy. We want your babies to come out with a ready level of protection of antibodies towards COVID as well. I think when I looked at the figures that we've had through, actually, there's lots of pregnant women who are getting the vaccination. So if that's you, well done. If that's something you're thinking about, you're not alone. Actually, 54% of the pregnant women, currently pregnant women in the North East London area have been vaccinated. That's fantastic. We want to get that number as high as possible. And actually, when I was looking at the numbers who have actually had vaccines across different places, I think it was 84,000 in England, 19,000 in Scotland and 160,000 in the US. And there have been no reports of safety concerns or serious incidents of in pregnancy to those mums who have had the vaccine in pregnancy. So I think, I think we can see that it's a very safe and positive thing that we can do. Thank you.
Thank you, Tamzin. So let's go to some questions if we can. So one of the first questions, great questions, he says, there are people, Ellen, who been vaccinated abroad in some overseas. Some cases, there may be different forms of the vaccine given in the UK. What's your view about vaccinating if they wanted to take some vaccines here? And what is our methodology in the NHS, at least from our side? So it's probably
so it's a really, really good question. Thanks for that. And that is extremely relevant, and particularly for some of our frontline staff, also international students coming in. So significant numbers of people coming into London, having been partially vaccinated elsewhere. And obviously the first aim would be to give them exactly the same product for the second vaccination, and then as per schedule, the third is usually either Pfizer or Moderna here, the booster. But sometimes that's not possible because, for instance, they might have received the Chinese vaccine, or they don't know which vaccine they have received. They just know that they have been vaccinated. So it's really usually a conversation with the GP to decide what is the appropriate vaccine. And just to say, there is also evidence. So ideally we would have, the second has to ideally be the same as the first. If that cannot for any reason been done because of the factors I mentioned, there is also evidence that mixing dose 1 and 2 is actually increasing effectiveness. So that is no harm done around that.
Thank you, Ellen, and that's important point. We do try to give the vaccine that is most similar to your original vaccine. There are different brands which have very similar mechanisms, so mRNA vaccines and so on and so on. But like Ellen said, there has been now more evidence to say that mixing vaccines actually shows to be quite effective, and especially in the boosters, we've seen that, for example, the Pfizer and the Moderna having the booster, which may be completely different to the previous vaccines, actually shows good evidence to say there's protection. So it is a fantastic thing that we are now able to think about vaccines in all sorts of ways now to help protect the population. Thank you, Ellen. So next question to the panel. One of our colleagues have said, look, the AZ vaccine falls to around 43% in terms of protection after 5 months from the second jab. So clearly the vaccination boost is a great thing. But the concern is, will we be going into vaccines every 6 months, the way things are going, Ellen? Do you have, from your point of view, from a public health, or Tamzin, have we heard anything at all that it's going to be every 6 months? I mean, certainly I've been told from my point of view 6 months at this point for the boosters, and in some cases where the third vaccinations for those particular groups of patients who are vulnerable will have the third vaccine, slightly different. But Ellen, I don't know if you wanted to take...
So I'm particularly grateful for the person who's posted that question, because I think we're so absorbed with the here and now and the pressures on getting people to have the booster in the first place, that looking ahead like you do by posing that question is often forgotten. And when I mentioned the possibility of any further booster vaccinations to an audience of social care workers the other day, they were actually very shocked because they hadn't thought about that. And I think it's safe to say that there is some likelihood that we will need further boosters. As to the time frame, that very much depends on our experiences with this booster and how long immunity stays at a sufficient high level to contain the pandemic and to basically limit the numbers of people who are becoming ill and require medical treatment, and particularly hospital treatment, at a level that we can cope with. So that is to a certain extent an unknown. But I think, yes, you're right. The booster was necessary, and we didn't know this to start with, and we now know it is necessary. There's likelihood that we need further boosters, and I think the last I've heard is like you, Jagan, was 6 months, but let's see what the findings then are once we're in that time frame.
Thank you, Ellen. And there's a question as well on partly on that, but it seems that the COVID vaccination is here to stay as a like the flu, a routine thing I have as clinicians in the system. It seems we have got used to. Would you agree, Tamsin and Ellen, that it seems that this is something we're expecting at least on a minimum as a yearly basis at this point, but clearly that may change as if things can be incorporated together and things like that, although we haven't been given any clue on whether that's the case, but certainly it seems to be here to stay. Would you agree, Ellen or Tamsin?
Well, I think from a public health point of view, I don't know, to be honest, because I think pandemics do run their course. And I don't know. I think it's very probable that it's here to stay for some time, but whether that's indefinite, like the flu virus, I wouldn't even be able to give. I was certainly not a definite answer yet, and I don't think it's very helpful to think in those terms just yet. I don't know, Tamsin, you might have a different view.
No, I was just going to say, I think it's we've all been existing in a state of uncertainty for a really long time now, and that can be really difficult. And I think we're so privileged in having quite a lot of certainties to do with healthcare in 2021, to do with lots of things. But actually, because this is such an evolving situation, we just don't have it with this virus. So as much as I think we would all like to be able to say what will be happening, I think the last couple of years have told us that it's probably best to just let things evolve and then, roll with them as we need to,
You're both absolutely right. I think it's difficult for us, and we are guided by the JCVI and our colleagues who are doing this work. And certainly it's very difficult to kind of promote understand the future. So I think that is the right thing to say really at this point. But certainly we're just dealing with what we have to in the next 6 months. After the next 6 months, as Ellen said, we'll know, get further direction going forward. So there's another question that's posed. A lot of the public have been quite confused about the messaging going forward, but there's a question again, Ellen. Why is the Pfizer now recommended, or the Moderna recommended as a booster when we were told not to mix and match? And I know you've answered that, but it just seems to be a question that keeps coming up.
Yeah, so that is it's an interesting one. So and of course, there's so many factors that play in there. Initially, we were very cautious and we didn't really know in terms of the efficacy in a bigger cohorts, and that evidence and in terms of efficacy was established over time. And it turns out that the group of vaccinations that Pfizer and Moderna are very, very effective. And so that's one factor. The other factor is also that this emerging evidence that a combination of vaccinations does have an advantage over staying with one vaccination. And then, of course, a third factor is the likelihood of any side effects. That is also, the profile is very favorable, particularly around Pfizer. So it's a combination of factors I can think of that explains that. That, of course, the other side is about ease of transportation and ease of administration. That is not necessarily only straightforward, particularly with Pfizer. So it's always a balance. And as we've now all said, there is a big global learning going on in terms of what brings the highest level and the most consistent immune response. And that's what we found out, that particularly Pfizer and Moderna provide that.
Thank you, Ellen. And Tamzin, question to you, if I can. So, good question. Why has the advice around vaccinating pregnant women changed from when the vaccine first came out? And of course, naturally, our colleague is saying, well, it makes it difficult to know why it's now safe if the government thought it wasn't to begin with. any views or comments on this?
Yeah, so I think this is a really tricky one, and it was a a question that we were all looking for the answer to when the vaccines were first coming out and being used. And I think, with anything to do with pregnancy, with advice, we're always very, very cautious. And we always want to see evidence before we start recommending something. And I think we were already seeing some evidence in the USA at that point, but actually the JCVI wanted to see some more outcomes before they started recommending it. I think, that's a reasonable approach, but I think what it has, an unintended consequence of that has been this worry about the kind of the difference in the advice and how is it safe all of a sudden. It was safe anyway. I think if we think about the biological mechanisms, like how the vaccines work, that's something I find very interesting, and I've looked at in lots of, well, not as much detail as lots of people, but there's no reason, there's no physiological way that those vaccines should or could cause any damage in a pregnancy or to your fertility or to a baby. So I think lots of us in the maternity world were thinking, actually, we think this should be recommended for pregnant women straight away, but we obviously have to be guided by the advice that is being given nationally. So I don't know if I've answered the question. I think essentially the answer is that actually we often have to be very cautious, and I think there's historical reasons for that are very, very sensible. But actually, what we're trying to get across now is that the message is that it is really safe. We've seen so many people have it and not have any bad outcomes at all. I was spending time with a friend in her COVID vaccinated baby. I gave her COVID vaccine in pregnancy, and she was absolutely fine, and she's been protected from COVID, even though her mum was working on the labour ward all the way through her pregnancy. So I think it's an unintended consequence that we're trying to kind of put right now about caution in pregnancy, really.
Thank you, Tamzin. And I think the other thing I just would like to add to that is the Pfizer and Moderna vaccine. There has been a lot of, as Ellen has said, and Tamzin, there's a lot of extensive experience with those vaccines in pregnancy. And there is experience with AstraZeneca as well. So I think it was Public Health England in their Green Book, they mention that really it was down to the fact that we've just, as Tamzin said, it's iterative. We've got a lot of experience with those vaccines, and hence the decision was made that way. And like you said, Tamzin, I think part of the other thing is that some people have started the vaccine. We obviously always recommend to try and, is that right, to complete the vaccination course using the same product, unless obviously there's a contraindication, but i.e. there's a reason why they can't. But as soon as you are vaccinated, we should, as soon as possible after pregnancy, we should just try to complete it, because it's about that. Is that right? Would you agree with that, Tamzin, the approach with as midwives?
Yeah, so if you've had your first dose before, say before you realised you were pregnant, and that was AstraZeneca, we would actually still recommend that you have your second AstraZeneca. And I think the reason that the recommendations are that if you haven't started, you go to one of the mRNA vaccines, so Moderna or Pfizer, is because of the amount of evidence we have around those in pregnancy, and also looking at the criteria in terms of age with AstraZeneca does come into it as well. But it's not to say that it isn't safe to have the AstraZeneca. We just have lots more evidence around the safety of the mRNA vaccines in the pregnancy. So I think we have had questions come through where somebody's had one AstraZeneca and they'd rather not have that again in pregnancy for various reasons. So we would always direct someone to a doctor, maybe an obstetrician, to talk that through if they wanted to do something different. But actually the recommendation is that you carry on with your same one. And really you can, just to reiterate, you can have it at any point in pregnancy. So from week 2 to week 39. And what we're seeing now is that actually, I think lots of people have thought, actually, you know what, I'll have it, but I'll have it after the pregnancy. Don't wait. It's dangerous to wait. So please do protect yourself as soon as possible.
Great. Thank you, Tamsin. And I think you answered the question about when can you have it. So that's great. Thank you so much. So Ellen, bit of a topical question, do you think we'll go into another lockdown to protect the NHS? I'm not sure I know it.
I think the question, I like how the question is phrased. It's like, should we? Should we be? A really good question. And a lot of people are pondering over why do we see what we see in the UK, that at the moment we're still holding out. And while we do have significant numbers of people very ill in hospital, we're not going into those extreme increases as we are seeing in European countries, where lockdowns have now been initiated. You've all read about them. And one of the reasons, and that's the reason that's most often talked about, is the vaccination rate. But it doesn't explain it fully. There's another element, and that is that because we've had such high levels of circulating virus, there is also a significant proportion of people in our population in London and in the UK at large that have developed infection-based immunity. So they got the virus and the body produced an immune response. So that also helps kind of protect us from spiraling out of control very rapidly. So at the moment, I don't think there is any immediate conversation about lockdowns because of that sort of relative steady state. But what we do need to do is to, and that's my personal view, my professional view, and I said that early and I tried to convey that in my introduction, is not rely solely on vaccinations, but continue with those four-pronged other messages, which is continue your COVID-safe behavior, hands, face, space, circulating, because it's a circulation, ventilation, because it's an aerosol that hangs in the air. The other thing is get your COVID and flu vaccine to protect yourself, particularly during the winter. The third is when you're feeling ill, and that can be very mild symptoms, stay at home and take a PCR test. And if that's positive, you have to isolate. And the fourth is test regularly, even if you have no symptoms, with a rapid test. So don't go to work thinking, oh, I'm doubly vaccinated, nothing can happen. You still need to try to reduce the transmission of the virus.
Thank you, Ellen. So the next question I'd like to ask, if I can, is it an assumption that people who are vaccinated are less dangerous to others in terms of transmitting COVID? And at the time we were told you can still get it and you can still transmit the virus if you are. What is the truth? Have we got any quantification? And, say 5 months after the second jab, does that mean that that your ability to transmit COVID goes up because, with the vaccine waning? So I just needed to just really kind of a couple of questions, Ellen, is about, the transmission with the vaccines.
So it's kind of related to what I said earlier. Yes, there is a reduction in likelihood of transmission, and the latest figures I've read is that it's reduced to about 60%, so 40% reduction of likelihood of transmission. But that's, of course, it's very difficult to establish, and I'm sure that the evidence will emerge around this. But what I said at the beginning still holds true, that it doesn't protect us completely from harboring the virus, getting a mild infection. You know, clinicians will see that. You get infections despite being doubly vaccinated or probably even boosted in a few months. But the aim of those vaccinations are to prevent serious illness, hospitalization, and death. So I find it's difficult to put a sort of hard number on this, as you sort of asked for in your question, but it's in the region of that I quoted. And yes, you can sort of assume that it's less likely, but it is still important to continue with those other measures. You're on mute, Jagan.
Thank you for that, Ellen. So the next question I got, again, is how do I know the vaccine is safe for my child, and do 16 and 70-year-olds need the vaccine? Well, I can answer that. I mean, the answer is yes. We have looked at substantial evidence in this group from not only here but across the Atlantic, who vaccinated the 16, 70-year-olds well before us. And there is a protection of around 80% roughly of serious illness and of course hospitalization. So it is very safe. We haven't seen any untoward effects as well. Of course, we're always monitoring it, but it has been, we were slightly later than a lot of other countries in terms of vaccinating our 16 to 70-year-olds. So I think the JCVI did the right thing. They looked at the worldwide evidence, they looked at the safety profile and made the decision on vaccinating. And I've had my children vaccinated as well. So, so I do think it is safe. I think it is, there's always going to be the odd cases of someone having a mild reaction of some kind, but in general, it's been a very successful campaign and I would recommend it. Now, if I look at the case rate, Ellen will probably have comments on this, but if I look at the case rate, interestingly, the highest proportion of case rates are in those age groups, that 12 to 15, 16, 17-year-olds across Northeast London. They're the ones who seem to be getting the most infections across our system in Northeast London. So I think there's an argument there that the biggest group of people that seem to be getting ill, and you can understand why, they're at school, they're mixing, they're traveling, all these kind of things. And so I do think it's something we should encourage, and I know sometimes it can be a very difficult discussion, and I would say that if you're not sure, vaccines, there's nothing to mandate any of your children to take the vaccine. You can go to the vaccine centres, you can have a discussion with the clinicians there, and you can make a educated discussion with and a decision on the basis of there is no mandate that you must. It is still a choice, and I'm sure Tamzin has the same approach with pregnant women. In her, it is a discussion, it's an agreement, and so on. And if you're not sure and you want more information, there are plenty of sources that I'm sure we can send to you, but also to help with that decision making. The next question I'd like to ask, if I can, Ellen or Tamzin, about the age factor in AZ. We've heard about the 40-year-old kind of cut off. Below 40, it's the Pfizer or Moderna. Can you talk about at all anything about the age, Ellen, of why those vaccines?
Yes, happy to. So in terms of the AZ, after that was introduced, we experienced sort of an accumulation, still rare, but side effects in younger people, and you all remember those blood clotting, quite worrying side effects, and that was predominantly affecting younger people. And that's why this age recommendation was introduced fairly soon as a response to that.
Thank you. Although the numbers were still relatively small, it was a decision that we think, and I agree with the JCVI and others and Public Health England, that this was the right thing to do going forward. And a bit of a tricky question, Ellen, the Botswana variant, and there's a particularly nasty spike version and the multiple mutations and the current level of protection in the vaccines. And how are we monitoring it? What's the research? That kind of thing in response to these threats. I mean, it's a very valid question. There's always going to be variants, isn't there, Ellen?
Yeah. So that particular one refers to, I think it was a Guardian article today, actually, that spoke about that variant. So what we are doing as part of the UK Health Security Agency is a constant monitoring of global genome sequencing of virus samples and looking at the distribution of those spike proteins and looking at variants as they emerge. And then that goes through a very, very intense scrutiny process to categorize them. First of all, if they show certain patterns of being infectious and spreading and clinical symptoms, then they first become a kind of variant of interest. And then if they're particularly concerning, they become a variant of concern. But there's a lot of work and scrutiny on a daily basis goes into that. And it is not confined to the UK, but it's a global effort. And while the UK was probably one of the very first countries with considerable expertise and scrutiny of those genome sequencing, that the world has caught up, and this is happening now pretty much everywhere. Now, this Botswana variant shows a particular pattern of those spike proteins that is similar to other variants that are spreading more easily. So that's why that's made the headlines. But as we kind of experienced with the Delta, you remember that the Alpha was the predominant one first, and then the Delta variant, where we then quickly, we were reassured that the vaccine protects us from serious illness through the Delta variant. So it's really, that was a very reassuring kind of experience. And we will just have to see how this continues. And it could, there is still a possibility that there are variants that might have the capacity to evade the current vaccines. But so far, that hasn't happened. And that is actually, in the course of over a year, a very, very reassuring. And I wouldn't, just because that variant has made it into headlines, I wouldn't be that concerned, because it's also a relatively small number of cases of samples they've found.
Thank you, Ellen. Okay, so question maybe to Tamzin. How bad is it in the hospitals at the moment with COVID? What's your kind of reflection? Oh, can you hear us, Tamzin?
Sorry, my internet's been playing up. Could you repeat that?
I said, how bad is it in the hospital at the moment, what you're seeing in terms of COVID?
Well, I suppose it's difficult to say, isn't it? Because it's all relative, and I think it's not currently as bad as it has been. But then if I think back to pre-COVID, imagining seeing things as they were was just kind of completely alien. So, my experience recently of heading into ITU was that there were lots of people there with COVID. And I think the thing that we're seeing is when you're in the hospital, there are other people who are really, really unwell. You're not seeing the many people who are going around and maybe having a mild case. But what we are seeing is that the people who are in the hospitals are who haven't had their vaccines. And the reflection that we've had from pregnant women we've spoken to when they have come back to us from having a spell in ITU or in other parts of the hospital and they've been really unwell, is that they wish they had. And I think that's probably just, you know, the main reflection, really.
Thanks for that, and I appreciate it. Put you on the spot, putting through obviously being a midwife and dealing with mostly pregnant women. But obviously, you know, compared to what it was, clearly our hospitals, it's better than that. You know, in critical care, we're roughly around, there's 34 patients in ITU across the system, which obviously changes, as Tamzin said, it's all relative, it all changes. So it's not a huge percentage of the bed occupancy in terms of ITU and things, but we still are getting large numbers of infections across the system. And part of this is actually quite a successful vaccine campaign across North East London. So, you know, some of the things that Tamzin is saying and colleagues in the hospital is actually seeing the reason, very much what Ellen's point about actually preventing death and serious illness. The vaccines, in my view, are successful, hence why we as a system are very keen to vaccinate our residents and patients going forward. But Ellen, there's a question, Tamzin, you know, and you know, there are people I would saying, you know, why are we not getting serious about vaccinating? Because, you know, of those 34 patients, all of them are not vaccinated. And why aren't we taking this seriously? There are still quite a few people across the country dying per day. 2% of the population have long COVID. We are now starting to see, Ellen, in children, you know, long COVID, although very little, very compared to adults. And of course, as you know, our A&E and ambulance, we're in the middle of winter, it's flu, you know, our hospitals are absolutely rammed in A&E, and anyone or the public who've ever been into hospital know it's very difficult for our colleagues in the hospital in the front line. And that we're not really, the message here from one of our colleagues is, you know, we're not really taking it serious, we're not over it. There's lots of social media and advertising and concerns about examples of not wearing those simple things like mask, Ellen, and I certainly have reflected on that going on the train in East London. I was quite shocked actually how many people aren't still wearing on public transport those masks or doing those simple measures, as we said. You know, there's obviously the legal requirement for our clinical colleagues in the system to try and now from April to be vaccinated as a mandatory thing. And we know our health and particularly our care homes as well, and we've asked our staff to be vaccinated to protect the residents and of course protect themselves. But what's your view, you and Tamzin? You've seen this across the system, but are we taking it seriously enough, or is there been a bit of waning in the population? What's your views? It's a general question, it's a fair question.
Yeah, it's a really good question. And it's of course complex, the question. So one part of the question is about, are we taking it seriously enough, and are we a little bit fatigued in terms of and also our role models, or let's say, or the visible people in government taking this not seriously enough? And the other part of the question is around mandation. So let's start with the not serious enough. I completely agree with you. It's not serious enough. And I think the messages that we are trying to convey to you in this call should be conveyed from, you know, in terms of everybody should role model those behaviors. While the vaccination has some element of reduced transmission, as we said time and time again now, the main aim of vaccination is to protect us from ending in hospital or dying, and particularly those who are really clinically at risk. And so pregnant women and those with underlying conditions are older people. And if we want to address transmission, we have to remain serious about those other measures, and we have to model that. And each individual, you know, us here, each one of us is kind of basically has to contribute to that, to model that. And we're at a difficult position at the situation at the moment, because I think that is happening. There is this kind of fatigue. And from the government's point of view, the winter plan consists of two parts. So it's the kind of part A and plan A and plan B. At the moment, we're in the plan A mode, which basically none of these things, with small exceptions, are being enforced. But should we get into a situation where we're kind of seeing a spiraling out of control, and particularly also pressures on the NHS that we cannot manage anymore, the government will trigger Plan B. And Plan B then is again with mandation, and it could also have components of, you know, more enforced lockdown type measures, which may be confined and regional, whatever. But at the moment, as we said now, this is not the situation we're in at the moment. But I do personally and professionally think that those other measures that I talked through, those four-pronged measures, they need to be taken much, much more seriously to be able to, for us to stay in this more or less steady state. Now, in terms of mandation, I think it's from a societal, sociological point of view, and in terms of our kind of values as a nation, it's a very difficult concept. It's not without precedent, as you said, Jagan. So we've had hepatitis B vaccinations for healthcare workers, for instance, is a mandated vaccination, and that was never the intention here. Even in other countries, the intention was to find a way to create what we call herd immunity state, so vaccinate enough people to reduce the likelihood of the virus multiplying in a community. So for instance, for the measles vaccination, that herd immunity is achieved when 95% of people are vaccinated with the MMR virus. So we don't quite know yet where that is with this virus, but the intention was never to kind of force everybody to have the vaccination. That's still not the case. But in those people who are dealing with vulnerable people because of their work, the government, and guided by the JCVI, has come to this recommendation that there are situations when you have to mandate this vaccine. And even though it doesn't protect people 100% from passing it on, that makes a difference to protect those vulnerable who these members of staff are looking after. So that's the context. But I think it is an interesting, I'll choose the word interesting, that some countries seem to go down the route of mandation. So that we'll just have to watch and learn. I don't think that's imminent in the UK.
Thank you, Ellen. Tamsin?
Sorry. Yeah, I was just going to reflect on the issue about how many people wear masks on public transport. And I think, you know, the thing that Ellen was saying around the kind of fatigue, there's, you know, psychologically, there's only a certain amount of time that we can all remain in that kind of, you know, panic mode where we actually do exactly as we're told on the whole by the government. But we also see that when there are mixed messages, it's the same with pregnancy and vaccination. When there's mixed messages, people with their, you know, variable feelings or kind of leanings towards risk will make a decision based on the person that they see doing the thing that they would like to be okay. And I think that is what we're seeing. I mean, I take public transport into work and do sit there thinking, I wish more people would be wearing masks. And you know, with the weather getting worse and what we know about this virus, actually that's only going to become a bigger point. And I think the other thing I was thinking about when we were talking about, you know, healthcare staff and hospitals and the winter that we are going into is around the number of people catching COVID who are staff members. So maybe they're not becoming very, very, very unwell because lots of people are vaccinated. But actually, if people still need to take time off work, then that's less staff available at the hospitals. And that's an issue that we've all been struggling with across the NHS recently. And I think if you kind of extrapolate that out, if you're a person who accesses a healthcare setting and you are vaccinated, everybody who does that and everybody who gets vaccinated brings those infections down and wears a mask and kind of takes those measures, you are down the line protecting other people who are needing to go into hospital for any reason, not just COVID. And there's lots of reasons that people have to come into hospital for. And what we want is hospitals that are really well staffed with people who are safe and physically well and in a position to be able to give the very best care to all of our families and friends and loved ones who are coming in and needing care from us in the NHS.
Thanks, Tamzin. Not letting you off the hook yet, but male fertility and female fertility. What's your views? And obviously, this is something that a lot of our patients, collectively, our patients worry about. To have babies, but also just in general. Any of you as a consultant midwife, what's your message?
I mean, there's absolutely no reason scientifically, physiologically, why these vaccines would be a problem for fertility. So the last webinar I did, we had one of our fertility consultants on that call who was just reiterating that message. And actually, we had a lady on that call she'd already given birth to her baby because she had her vaccine during her IVF treatment. And she kind of spoke to her healthcare providers. She read what the evidence was, and she said, I'm happy to do that. And actually, I think over recent months, we've heard from more and more men who are worried about their own fertility. But I would say that, the way the vaccines work, some of them, like AstraZeneca, is a very old style of vaccine. We've had vaccines like that for a really long time. It's just that you put whatever it is from the new virus that you want to protect people from. So actually, there's lots and lots of evidence around the way those vaccines work and the fact that they won't affect anyone's fertility. And actually, the mRNA ones, which are a bit newer, we've actually been developing those for 20 years. And again, that science, things don't sneak up on us and we get to use these new technologies really quickly. It's just, and I know this has been emphasized lots of times before, but the reason that we've got these vaccines so quickly is because of the enormous global effort to make it happen and massive amount of money and special measures to kind of do the processes that we always need to do, but just much faster than we would normally do them. So nothing about these vaccines is new or really, really untested. And there's no reason why they should affect your fertility. And actually, if you think about being as healthy as possible going into making a baby, actually being protected against COVID and not having long COVID and, feeling really unwell and generally not at your best is actually going to be better for you in terms of going into a pregnancy or going into a process of making a baby.
Thank you. So, and I agree with Tamzin's point. There's actually the mechanics of the vaccines. It's impossible for it to do that in terms of affecting fertility as well as obviously the baby and pregnancy as well. So, and like Tamzin said, these vaccines have been developed for all sorts of other things other than COVID. And we've tested this on certain things. I know the mRNA vaccines have been used in cancer and things like this. So there are lots of other things that we do. This isn't new technology. This is something that's been, as Tamzin said, it has just been applied in this role. So Ellen, it's fantastic questions and really helpful. So Ellen, do you think two questions? Do you think we'll start vaccinating younger children? And can I have the flu and COVID vaccine within a day of each other?
Okay, so the first one, really good question. As we have seen that sort of Israel and the US have started to vaccinate 5 to 11-year-olds 3 weeks ago, I think. Actually, the US slightly earlier. And the European Commission has certified the vaccine safe for the same age group, I think yesterday or the day before. So they are going to start that too. It is quite likely that we are going to start vaccinating that age group too. And just to add to the conversation, it's a little bit, despite everything we've said about the protection of vaccinations not being complete from passing it on, there is an effect. Now, if we, and Jagan, you said the highest peak of infections is actually in those 10 to 14-year-olds in northeast London. So the aim of vaccinating the large groups, not everybody, there is never going to be mandation, certainly there, but large proportions of young people is to reduce transmission as well as to protect them. But we do know that young people tend to have very mild symptoms. Very few get ill, but if they have underlying conditions, they need to be particularly protected. So there is another element here of reducing transmission. That's why we want to vaccinate young people. And we particularly the experience from Israel shows that works. So yes, in answer to your question. The other question is relatively straightforward. Yes, you can have not only just a day apart, but on the same day, in the same session, one arm COVID, other arm flu, get them done if you're lucky enough that the provider you've chosen can do them. Not everybody does, but that would be the slickest. And you just get your protection, because we're now going in the winter. While flu levels are still very, very low in London, they will ramp up eventually. And our immune system is not prepared because we've been in and out of lockdown for so long. So get your flu vaccine.
I actually had both flu and my COVID booster in the same arm on the same day, because actually I thought to myself, I'm a side sleeper and I want one side that I can still. So I had them both in the same side and I was absolutely fine. So yes, get them over and done with in one go. That was my thinking.
So a couple of questions, we've got a few minutes left. So to the panel, Ellen and Tamzin, what's the right thing to say to vaccine hesitant family friends? It's a difficult one and I'm not sure we could probably go on forever for that thing. And, maybe a couple of one-liners. And then Elizabeth also puts a question about what communities have we been worrying as leaders in the system? And then there's one more question.
I would say in terms of speaking, family or friends who are vaccine hesitant, with anything, and we see this with, differences in opinion on Brexit and anything else that we've had very polarized views on in a few recent years, is that you don't change minds by coming in with a kind of conflict vibe, for want of a better word. Actually going in and coming in with curiosity and trying to find out what it is that people are worried about and what it is that they think the issues are, is much more likely to open up a conversation where you can share your views or what you've read, or you could explore where people are getting their information from, because actually, we know that there's lots of fake news and there's lots of people sharing things that aren't actually, they don't have any basis in evidence, and it's often based in fear. And I think coming in with curiosity and rather than telling someone that you think they are wrong is probably going to be more helpful.
And I think that the communities, Ellen, do we have anyone that we're worried about in our system? Communities.
Yeah, so in terms of, so first of all, what I always repeat is initially we're concerned for our clinically vulnerable people, for those with underlying conditions, for the very old, and for pregnant women, really concerned. So let's make sure that they are getting the information they need. And then in terms of other groups and populations. There are, of course, groups that, because of the way they are forced to live, are more vulnerable because their immune systems are generally weaker. For instance, homeless people, so marginalized people, and those who are at higher risk of actually catching it because they live in overcrowded conditions and poor general immunity because of poor diet. So as a public health professional, this is my daily work, and identifying in Northeast London, for instance, where are these people, what are kind of on a geographical level, so where are the highest level of illness and the lowest level of vaccination. So in terms of vaccination uptake, I'm personally, and as well as everybody else in that professional world, is concerned about Black African, Black Caribbean, particularly younger age groups, particularly men, where we see low percentage of uptake of the vaccination. And then there are other population groups where uptake is just very, very low. And that's our work targeting. And it's really quite complex. It's like a kind of pattern, a combination of different factors. We know that some areas, often to do with deprivation, more severely deprived areas, tend to have lower uptake. That in combination with, for instance, some ethnicities that tend to have lower uptake. None of this is kind of fast and fast. These are like proxies. These are indicators that help us to then go in and work with communities, give them as much opportunity and information as they need to get vaccinated. But I think the core principle is the more vulnerable in terms of clinical terms people are, the more we need to make sure that they are actually getting vaccinated.
True, and I think it's been, I'm working with our community groups, something that myself and Ellen and others have been working with those community groups, those voluntary sector groups, those faith groups, and it has been a critical part of our campaign to help with the messaging, because the NHS doesn't always know the right messaging, and also doesn't always understand the the reasons why they have apprehension about the vaccine, and it is multiple, and we respect that, and I think we embrace the differences, but of course we must be. It's also a listening exercise for us to help with the vaccine campaign with our residents as well. So I think it's a very good question. I think I would like, last question is about long COVID. Obviously, there's a big fear of long COVID, and I don't know the answer to the long COVID. If you're double vaccinated, what's the chance of you getting long COVID? Now, in my practice, and I'm just talking from, and it's something that we can always come back to, but in my practice of 24,000 patients, not a single patient who had long COVID, because I was looking at this and doing some work on long COVID across Northeast London, where all of the patients who have long COVID are actually patients who weren't vaccinated. So I can't really say, I don't know, Ellen, if you do know the fully vaccinated long COVID numbers. I mean, there's always a chance, of course there is, but I don't know the numbers off by heart. Ellen, do you have any idea?
I also don't know the numbers, and because I think, let's not forget, overall it is a rare event, long COVID, and also the evidence and our learning around this, we're still on a very, very kind of protracted learning curve to understand what does it actually consist of and what are the symptoms to look out for. And I think, I like you, I can't quantify it. It's likely that fully vaccinated protects us, but to what extent it protects us, I can't answer that question. And I really feel for you to put that question in the chat. And of course, we can protect ourselves with those other measures that we now talked about time and time again, in terms of minimizing the risk of getting infected with face masks and so on, and keeping our immunity as best as it possibly can be.
And I think I think the message here is, and I'm going to end this, we are slightly over time, and thank you for those fantastic questions, and thank you for our fantastic panel taking their time out from their busy work schedules to come and help and support us. But I think the message is right, and I think one of our colleagues have said, let's, doing these things, vaccination, mask wearing, washing hands, keeping safe distances, taking those tests when you think you might be ill, regularly testing. Actually, that's the biggest thing we can do to not only protect ourselves, but protect other people that we love, our friends, our colleagues, and actually our society in general. And this is about our message to you, and we're always very happy to take questions offline, but is try and encourage our colleagues and friends. And if you're not sure, there's always other forums to have discussions. There are vaccinations. If you're convinced by the three musketeers on this call, by us to say that we convinced you, please go to the National Booking Service or call 1119 and get it booked in. And of course, if you're still not sure, the vaccination centres are always happy to take on, questions. And people like Tamzin and Ellen and myself as colleagues, we're always happy to, with our patients and residents, always happy to help answer questions. And the information is on our website. We're very happy to take on, but let's encourage, let's get North East London back on its feet. Thank you very much, and I wish you all a very good night. Stay safe, and hopefully we will have a lovely Christmas and a new year. Thank you very much. Thank you.
Thank you, Jagan.